Thank you very much, Alex. Good evening, everybody. Firstly, thank you very much indeed to the Institute for the opportunity to come here and share what we've been doing in terms of the national development work in Scotland. Absolutely delighted to be here to do that, but more importantly to see the launch of this white paper on human factors in healthcare, which I think will be a significant milestone both for the Institute and for the wider service. So pleased about that. We've got a title here that our development group came up with, Performing Well and Feeling Well, which is a reflection both of what the aspiration would be for staff and for patients and families. So I'm going to focus on, in the development work, on one aspect of it, and that's about building capacity and capability and what we've done, what we've achieved there, and what our plans are. So I work for NHS Education for Scotland, or NES, and for those who don't know, in Scotland, that's the main education and training body for the healthcare workforce. And we've been co-leading this work with the College of Surgeons in Edinburgh, and I must pay tribute to Simon Patterson-Brown, who's a consultant surgeon in NHS Lothian and a past patient safety lead for the college. Without his drive and enthusiasm and energy, we wouldn't have achieved what we did. Simon's been absolutely magnificent to work for. A bit of background and context then. So Scotland, or the NHS in Scotland, has a bit of an international reputation in human factors and has done for perhaps 15 years or so, particularly around the fields of non-technical skills, clinical skills training, team training, and in the simulation world. And so we've got international recognised experts in those fields. And so I was a bit reluctant to become involved when I was pushed to the forefront by my medical director to go and work in tandem with the college and also to bring together all the key players in Scotland to try and raise the profile of human factors and the benefits of it and the need for it in the service, mainly because I was in a bit of a kind of Donald Trump type baby huff with what was going on in terms of human factors, and I'd retreated to my bunker in frustration. And these guys have got international reputations, and I'd never led a national piece of work on this scale. So I just closed my eyes and got on with it. And I must admit, it's been a wonderful learning experience, and things have progressed much more seamlessly than I thought would be the case. And there's been very few bumps in the road, although it's been a slow burn as such. So the reason for that, and you probably see the third bullet point there, is around the myths and misunderstandings that prevail and still prevail around human factors. And that's where a lot of the frustration had come from. I probably didn't have the skill set over the last decade to try and be as inclusive as possible and to work in tandem with those who had different perspectives on what human factors has been about. But I would like to think I've since matured then, as with one or two of my other colleagues in Scotland. So that's a bit of a kind of background issue. One other thing that had happened preceding that is that I decided unilaterally, as part of my educational development work and my health services research work, that I would only work with qualified ergonomists. And that has been, I would think, and my colleagues think as well, a real success factor. We just basically get fed up of, and I don't want to be disparaging, but airline pilots charging £1,200 a day around the service, being very entertaining about human factors, but really getting nowhere, and perhaps perpetuating the same myths and misunderstandings. I'm glad to say that that's changed slightly in Scotland, and I don't know what it's like in the rest of the UK and Ireland, but certainly that was our experience. So the National Development Group itself, I'm jumping to the end here slightly. So we started off, I gave a presentation the very first time. We got everybody together, those with an interest in Scotland, and I gave my take, or really what the Institute's take, or the Wilson and Sharple's book take on what human factors was about, and I was met with kind of stunned silence at the end of it. Two extremes here. One, a very eminent surgeon called me a geek and a purist, and another surgeon says, reflectively, so we've been doing this wrong then. And neither was kind of right, hopefully. But that was where we started. And it's been magnificent to see that 2 years down the line, there is a shared understanding, a shared common use of language around human factors and ergonomics. We have now got surgeons and anaesthetists and nurses talking about ergonomic problems, ergonomic design issues. We need to take a human factors-based approach to that. That isn't a systems-based approach. It's been magnificent to see. So the understanding of human factors for all of us has matured and broadened beyond what our initial specific areas of interest were at the time. And I must pay tribute to colleagues from the Institute who are listed there, who we've worked with and who, to some extent over the years, and some more than others, but everybody's made such a valuable contribution to the work that we've done. And in particular, I want to pay tribute to Neil Clark, Steve Shorrock and Sue Hignett, who are officially the world's cheapest ergonomists, and who have given freely of their time and expertise in exchange for cups of tea, biscuits, curry and beer without payment. So thank you very much indeed, that's truly acknowledged. And so who are we? So this development group I've been talking about, so I've got 150 plus, probably nearer 200 now, multi-professional team representing all these different professional groups and institutions. I mentioned the fact that there's representation of simulation, non-technical skills training, but also from the clinical risk, patient safety, quality improvement world, clinical governance, occupational health, medical devices, etc. We've run 4 workshops, so we've been working on that basis to try and get this development going. The logos there don't represent everybody, it's as many as I could fit in the slide. So what did we come up with? What was our priority? What were we trying to achieve? Now this was the original priority. Okay, I'll come back to this at the end. So to develop this strategic plan for the integration of HFE, principles and methods in health and care, policy, practice, education and research in Scotland. So this contrasts with what you did in England 4 or 5 years ago, when policy and still is trying to drive implementation of human factors. What we're trying to do in Scotland is the opposite. We do not have a policy. We are trying to speak to the Scottish Government about can we get this officially embedded as a policy. And that against a background where the strategic priority, or priorities which are probably most closely related to this, are around patient safety and quality improvement. They are king. So that's the kind of context we're playing with, although we've got all those major players on board to some extent. So what was our vision or our anticipated outcomes? By doing this, okay, we hope it would lead to the joint optimisation of system performance and human well-being. This was agreed at the second meeting, and this was my first inkling that things had progressed. For those who don't know, these are the twin aims of human factors. This is the purpose of human factors as a discipline. And so we had bought into that once all the clinicians and the others in the room had started to get it. And that was the most pleasing aspect at that point, that things were moving in the right direction. And so what did we agree and what have we agreed? Okay, so we've got 5 areas of priority. We can't do everything, okay? Human factors is about all aspects of human work, and we can imagine the scale and complexity of that within the service and within social care as well. But those are 5 areas. So I had first put forward the idea of setting up a kind of national special interest group, and that was immediately kicked into touch because I was thinking too lowly. That was called a corner shop approach, and really what we wanted was Walmart. And so the idea of this national advisory group would sit a body that would be influential, would be staffed by experts, and would it'd be advising the Scottish Government and territorial health boards, etc. But what I'm going to focus on, and you can see the 5 areas there, what I'm going to focus on in particular is the building the workforce and capacity and capability bit, and learning from events plays into some of that, as does the bit about design principles, number 5, and getting them implemented within national programmes as such. So, our vision for building capacity and capability, and we've made some progress in these areas, okay? So we want it integrated at undergraduate level, in postgraduate training, in clinical appraisal for all professions who are appraised, and in CPD arrangements. In the areas I've mentioned already, the leaders we've already got in place in terms of the guys leading in clinical skills and team training, NTS, etc. We're very lucky in that all the national safety and improvement programmes, educational programmes in Scotland are run by my organisation or by our sister organisation, so the key leads there are on board, and the curricula for those various programmes have already been integrated to some extent with kind of our human factors approach, so we've kind of done that work. We're working on standardising induction processes. What can human factors say to staff who are new to the service or new to a particular job in terms of induction? We've already produced an initial draft of an introduction to human factors for strategic decision makers, NHS board members, non-executives, people who work in government at a national policy level, who lead procurement, these types of guys. And then bespoke workforce education and planning as well around very important groups, middle and senior managers and executives within healthcare organisations. Sue's touched on the second last bullet point, which is absolutely key. I should have been first actually, but it's absolutely key to what we're trying to achieve. A minimum of one qualified ergonomist in each NHS board, territorial board, and special health board, which takes about to 18 or 19. Now, it's a complete drop in the ocean. I mean, we're talking about probably £2,000 to £3,000 to get somebody to postgraduate certificate level, okay? And I'll come back to ideas we've got about how that can be achieved, both in terms of who to target and the funding that may be available. Sorry, I've got that in the next bullet point. So a challenge I'm placing here tonight to the Institute is that, and you guys will know this, is that in every NHS organisation there are a team, okay, they might be differently named, there are a team of support and advisory staff there who work hand in hand with clinical care teams, and they are the clinical governance people, the patient safety leads, the quality improvement advisors, the organisational development team, the head of clinical risk and his or her team, okay? These guys all have an interest in what we've got an interest in, which is to try to improve how work is done. And so they're kind of halfway there. We don't have the numbers in terms of capacity and capability for human factors expertise, but these are the groups that we could target. These are the groups that probably need developed from a human factors point of view, and also professionalised. Many of them don't have that safety science, human factors professionalisation, which is suited to the types of jobs that they're doing. So to me, there would be an easy target group initially, running in parallel, obviously, with the clinicians who've got an interest in human factors and who've got themselves upskilled and educated or thinking of doing that. So that's my challenge to the Institute. What can we do for that particular group in terms of offering a technical specialist qualification and potentially supporting them? So what have we actually done? So we've been talking about wish lists, etc. So in terms of educational development around building capacity and capability, we have stolen from the Institute and Health Education in England the taster workshops and adapted them, put a tartan badge on them, increased them to 3 hours, and we've been running them for 2 years very regularly, and they're extremely well attended. Out of that, we've also got another 2 interlinked workshops around why do things happen in a complex system, and why do things go right and wrong in a complex system, and how to respond. Another workshop when things go wrong in a complex system. I mentioned earlier 2 flagship educational programmes in Scotland, the Scottish Quality and Safety Fellowship, where we train about, it's a lead level course, we train about 30 plus clinicians a year, and the Scottish Improvement Leaders course, which is both for health and care in wider public sector, but our organisation runs. We have now integrated human factors approaches within their curricula as well. I mentioned also about the fact they've developed this decision makers resource around entry-level human factors. I won't say anything just now. I'll go to the next slide about learning from events, system thinking and safety policy views, other than to say that Helen Vosper, who's in the audience, her and myself and Sue and Al Ross have been working, we've not been working very well in the last couple of months, but we're supposed to be working quite hard around developing educational case studies to be used for educators in terms of showing them how human factors can be embedded within their existing training programmes and curricula. And so Helen's been leading that. Helen's also leading, jump into the second last bullet point, the development of a book, a kind of field guide for educators on how to implement the human factors. What is planned is a 3-day residential course for those key groups I'd mentioned earlier. It can be open to clinicians as well, but those from the risk, safety and improvement world. And that's maybe one way we can begin to link up with the Institute in terms of accrediting that course, but also providing a mechanism or an avenue for these particular groups to become technical members of the Institute, and then from then on they can be professionally developed in some kind of way. I didn't say at the beginning, but my man-bearing gifts. So everything that I've mentioned here, we've got entry-level e-learning for the entire NHS workforce. We launched in Scotland a couple of months ago. I'm happy to share the storyboard of that and give it to you, along with all the workshop materials, and you can take it and adapt it to your own context and use it as well. So we've got lots of materials here that are free, open, very open to sharing all of them. So what could it look like? Okay, so what could integration of human factors principles within postgraduate training curricula, for example, look like? Now, I'll draw your attention to the paper, the headline there, it's in red, which is a good paper. I was a bit disappointed that it was an idea I had, but somebody beat me to it, which was to review the medical and surgical training curricula from a human factors perspective. The only gripe I have with this paper is it's got human factors content in the title, but essentially all it was looking to see who provided non-technical skills training or not. And so that got us to thinking. I work quite closely with GPs who are also patient safety researchers, and they're also general practice educators. It got us to thinking, let's critically review the GP specialty training curricula from the same perspective. And we worked with Laura Pickup, who's in the audience, and Sarah Atkinson from the University of Nottingham at the time. And what we did was to say, right, what are we training these guys for? We're training these guys to lead, to adapt, to function within a complex socio-technical system, where quality and safety issues are emergent properties of that system. So let's give them the knowledge and the skills and the wherewithal which is suited to the type of tasks that they're going to be doing. And so here are the human factors concepts on the left-hand side that we thought were relevant to that type of job, and the bullets show us where they could be potentially embedded within the existing training for general practice at that point. Now, the same principle, I would imagine, would apply to the other specialty training curricula, and indeed for pharmacy, for dentistry, for nursing. And so this is a project the Institute are very interested in starting to really finish that off, to demonstrate to the colleges what human factors integration within the curricula would actually look like. Other resources which are available in terms of learning from events. So we've led, Health Foundation funded, we've led some national development work over the last 5 years or so in taking a human factors based approach or a systems based approach to significant event analysis within the primary care professions. If you Google my own organisation, NES, then you will find plenty of resources on that and materials, and indeed some of the principles from that have went into our good practice guidance for mortality and morbidity meetings in Scotland. Again, we've been working closely with the clinical lead for the Scottish mortality and morbidity meeting, and we've got this good practice guidance, again, which is taking a human factors based approach. Still very early stages, it's still in draft. We're still trying to persuade people of the benefits of this, but we're making good progress. I won't say too much about systems thinking and human factors are still in early stages, but again, if you Google our website or ask me, I can send you information on this. One thing I spoke about earlier to a few colleagues is work we have done on organisational policies for the management of adverse events. So one organisation, I'll just give you one example, Healthcare Improvement Scotland, were quite happy for us to take a human factors perspective or a critical analysis of the existing policy and how organisations should manage and learn from adverse events. Now, we were very critical, and I'm pretty sure it's the same with all NHS policies that look at this. You know, I read them quite often myself. They say all the right things, but perhaps in the wrong order. It's like a jigsaw piece. It's all there, but it doesn't quite make sense. And that's not to blame anybody. That's largely because they've got non-specialists who are writing this, and non-specialists, by and large, who are picking it up at Acute Trust Hospital. And the blame game's still going on. We're still using linear cause and effect methods in a complex system. There's lots of different things that we can change and advise on. I need to hurry up because I'm over time, I've noticed. In the middle of all this, One significant development, the chair of my organisation, we've got a new chair. Let's just put it nicely and say he's human factors daft. He's been extremely supportive. He's told us to slow down with this work, to take our time, to get it right, to engage informally with all the key stakeholders. Do not go to Scottish Government at this moment in time to try to influence policy, because they won't be interested. Yes, they'll say that patient safety and quality improvement are their #1 priorities. That's just rhetoric. We all know that. What they're really obsessed about is targets and the regionalisation of health and social care. So leave it just now, prepare the ground, speak to the directors of nursing, medicine, pharmacy, get them on board. Our chair is also the chair of the chairs in Scotland and is also in charge of the professional development. So if we take it more slowly and we pick off all these groups, we've got a much better chance when it comes to Scottish Government. And so, some hard truths. Scratched the surface, made some good progress. We've got to remember, particularly in Scotland, I don't know so much in England, Wales and Ireland, but many of our leaders have been trained in quality improvement. We have got an aim of training around 10% of the healthcare workforce. QI is king. From a human factors perspective, we need to accept that, we need to work with them. We're never going to take over the world anyway, we know that. But it's all about adding value to what's happening in safety, what's happening in quality improvement and other areas that are trying to improve work. One thing I would say is taking a hard line can work. So I drew a line in the sand. We're only going to work with qualified ergonomists, and we're going to take the kind of institute approach to what we understand and mean by human factors, and it's worked by and large, which surprised me. Okay. So what we're doing next, our chairs are way to find the funding so we can give it to the boards to train up somebody. We've got 2 NHS boards who are actually keen to test the programme of work we'll come up with. We intend to review the WHO patient safety curricula, and we've also made some early links with the Academy of Medical Royal Colleges in the last month or so, and so we hope to try and influence what they're doing from a patient safety curriculum point of view. Helen Vosper, who I mentioned earlier, we've effectively got a free run at pharmacy education in Scotland. There's 2 universities, Strathclyde and Robert Gordon's. My organisation is the one who puts out the kind of policy around what's going to happen along with their own professional body, and so we can heavily influence what's happening from a patient safety human factors approach in that curriculum, and that work's just about to start. So, conscious of the time, I'll just finish there, I think. So thank you very much indeed for the opportunity to share our work.
So thank you so much, Paul, for coming and sharing all of that with us, and we look forward to working with you in the future. So that's what Scotland's doing. We look forward to working with all of you in the future as well. After the event, Chartered Institute will be chasing, contacting, nagging, nudging, all the above, to see what can we do to help you. This is a really important stage. As Ian said, it's taken us a long time to get the consensus, to get everybody on board, to work in a participatory way, and to launch this white paper. What human factors in healthcare and social care should and could look like. This is the opportunity, this is the start. It's going to take us 30 years, but we have to draw that line in the sand and say, okay, now's the time to do it professionally and work with the qualified discipline. I hope you've enjoyed it. Thank you so much for coming along. Please do stay in touch. Please do contact us around the white paper. If you would like an event set up, supported by the Chartered Institute in your region, in your area, we are very pleased to discuss that. We already have one planned for later in this month in the Midlands, thanks to Bryn and Julia for pulling that together. So please let us know if you would like to launch this and keep this going in your area, and we'd be delighted to work with you on that. Thank you all very much indeed.